Welcome to Medical Grand Rounds. It's a real pleasure to introduce Dr. Ignacio Sanz, Professor of Medicine and Director of the Division of Rheumatology and Immunology, and it's a real pleasure to welcome him back. So thank you, Ignacio.
Okay, thank you, David, and good afternoon. So we have been really thinking for quite some time that this is a topic that is really important for practicing clinicians in medicine, general practice, and subspecialties. And that, I think, it really is, in a way, documented by the really large volume of ANA tests that are ordered constantly, and in many cases misinterpreted, with really bad consequences, I think, for the patient clinically and emotionally many times because of misdiagnosis. And obviously financially in terms of healthcare cost and downstream testing and interventions. I wanted to show in the disclosures that although there are a few industry collaborations on my side, they are non-related really to the topic of today's presentation. And the objectives are going to be to try to understand the value and significance of the ANA testing in clinical practice, to discuss available ANA tests, because that really is a moving target, and I think is one of the main elements that adds to confusion, and to offer some recommendations for the use of this test in clinical practice. Dr. David Alter had the courtesy of putting this data together and gave it to me. The bottom line is that about 2,500 to 3,000 ANA tests are ordered at Emory just in the last year, and about the same, this is by Immuno-Fluorescence, about the same number by multiplex antigen testing that we will cover today. And I assume that this is actually only a portion of the tests that our patients bring for evaluation, because many of them are actually done on the outside in other labs. And again, that really adds to the confusion, and you'll see why that is. And then about 30,000 specific ANAs, individual antibodies, or some other panels were also ordered at Emory or through Emory in 2018. So we are talking about a massive amount of information. Obviously, there is some redundancy here. Some of the tests are for the same patient. Some of the tests may be in the panels or are individually ordered. But one way or the other, there's a massive amount of diagnostic values on which we rely to manage the patient. All right. So the first thing to know about the ANAs, and you'll hear me saying this again and again through the presentation, is that they are not specific. So this is the first thing that we all know but seem to forget frequently. An ANA test is not specific for an autoimmune disease and doesn't make the diagnosis of an autoimmune disease, lupus or otherwise. This is just a case that was presented by some of the fellows and faculty here a few years ago that was published. And that was just describing this African-American female with heavy history of tobacco use that presented with arthritis and was found to have a positive ANA test as well as anti-double-stranded DNA antibodies and so-called Sjogren's-related antigens A and B. So SSA and SSB. You see the values here. I'll get back to that in a second. But after proper evaluation, the patient was found to have a lung adenocarcinoma with hypertrophic pulmonary osteoarthropathy. Okay? Not uncommon. Lung cancer has very frequently high titers of ANA, and they may have musculoskeletal manifestations. The other thing I'll call your attention to is that although formally these tests are positive, if you scrutinize them, you'll see that the values actually are less than twofold over normal. So I think that you have to be very cautious actually putting any value on those numbers anyway. Okay. Now we are talking about one end of the spectrum, which is just taking patients that come for evaluation, doing ANAs, and decide the value of the ANA for an autoimmune disease. Now you can go to the other end of the spectrum, and that's illustrated here. That is, now you have patients diagnosed with lupus that are being entered in a very important clinical trial. These were the trials that actually led to the approval of belimumab or anti-BAFF antibodies to treat SLE. This was a hallmark in the field because this was the first drug and first biologic ever approved for SLE in 50 years. And yet it was about to fail because in the phase 2, actually, they didn't meet the endpoints. Now, after the trial, they evaluated the patients and they realized that about 30% of them were ANA negative, which is unheard of in lupus. And so either the testing was very poor or they were enrolling patients that didn't have lupus. Once that was corrected and ANA was requested as an entry criterion, a study worldwide, two actually, with more than 10,000 patients actually was positive and led to this important breakthrough in SLE. So the importance of doing ANA properly and in the proper populations goes, as I said, from pure diagnosis in the general patient population to the more specialized application for clinical trials. Now, the first thing to keep in mind in this context is that ANA is very common in the general healthy population. Okay, so it's not only not specific for rheumatic diseases or autoimmune diseases, but it can be seen with high frequency in healthy subjects. Depending on the study and depending on the population, 5 up to 30% of healthy subjects will have a positive ANA. This is a fairly old study in which it shows that frequency, obviously, lower titers are much more common than higher titers, okay? This is another study, large number of healthy females, a study over time, a different, not over time because it was not longitudinal, but over in different age groups, as well as on the basis of parity. Even though the prevalence of ANA depends on parity, according to this study, what you can see is that in any of the groups, an average of 15% of this healthy population was actually positive for ANA. There's another study published in part. These are the references, but presented by Ward Wakeland from UT Southwestern a couple of years ago at the ACR, and he kindly shared some of these slides with us, showing once again that if you do ANAs in a very large cohort of healthy individuals, almost 3,000, you will find 8% that have titers as high as lupus, and about 18% with moderate titers. So once again, this topic keeps repeating and repeating, okay? So I think we have established that a positive ANA test is very common in the general population. This is also true in children, and I'll show you a study about that later. And that's irrespective of the method used, but does it make any difference which one you are using? So this helps me introduce one of the topics of today, which is discussing the relative merits of these two main forms of testing for ANA. One is the traditional indirect tissue immunofluorescence that is performed on these HEP2 cells, traditionally been said to be epithelial cell line. Turns out that for many years now it's been a contamination with HeLa cells. But just the same, what it does is that you have all the antigens inside the cell exposed for autoantibodies that might be in the patient's serum to bind to those antigens and give you an immunofluorescence reaction when you add secondary antibodies. Now, the newcomers, now for quite a few years, are the solid phase assays. And here there are many different assays, and it depends on which purified antigens you put in these different assays. There are many different platforms. I'll show you some of them, including the ones we use here, and we will discuss that. But essentially what you can see here is that whether you use a solid phase assay, the Bioplex, which is probably the best documented out there, and for what Dr. Alter tells me, we may actually move to that platform here in-house in the near future, or in the immunofluorescence. And you say, again, comparable in the healthy population and fairly high in the healthy controls, as you can see here, either way. So this has very practical implications, as I said. These case records of the Mass General maybe 2 or 3 years ago, in which Woman presented with a rash compatible with livedo reticularis, tender cutaneous nodules, and atrophy blanche, mononeuritis multiplex, and blood cytopenias. And serological testing had been unrevealing. Eventually, she was admitted to Mass General. So here you can see all those negative ANAs, including the ANA by some of the solid phase assays. And it stayed negative together with all the other antibodies for several months. During the admission, the ANA was repeated by immunofluorescence. It came back at a very high titer. Okay. So the comments from the case records, which I think summarize the issue that we have, is that the most likely explanation for the conflicting results was the different screening tests for ANA. So you see a big discrepancy there. The laboratory at Mass General uses, like most rheumatology places, the immunofluorescence on HEP2. And depending on the dilution, that is positive in 95 to 97% of patients with SLE. The problem is that commercial labs for the other assays, solid phase assays, use a number of limited antigens, in this case 9, and a sample is just reported as positive or negative depending on whether one of the antigens reacts. Now the details of how the antigens are produced, purified, linked to the beads, and tested for stability are trade secrets. So you don't really know what you get. Sorry. Now, the changing in testing methods may result in failure to diagnose systemic autoimmune disease. And in this particular review, the sensitivity of a positive bead assay for SLE may be as low as about 50%, okay? So again, you will hear also again and again during the presentation that there are relative advantages and disadvantages of the two methods, but in general, the fluorescent ANA is more sensitive for the diagnosis of our diseases. You'll see the exceptions, but it's less specific, okay? So you have to keep that in mind for the screening phase. And this obviously illustrates the importance when you order an ANA to know what the lab is giving you, whether it's giving you one method or the other, so that you can really evaluate the results. All right. Now, is this consequential? Well, you saw a case here where it really led to misdiagnosis or lack of diagnosis for quite some time, but it has other problems as well. So over-reliance on ANA testing leads to overdiagnosis of SLE and over-treatment with steroids. And also, I don't think I can overemphasize the emotional impact that these diagnoses have on patients. So when the patients come, and many times have been carrying the diagnosis of SLE because of an ANA, not much more many times, and they have been ascribing their day-to-day problems to that diagnosis. They have received treatment and some other issues, maybe insurance issues, maybe other type of work-related issues. It's extremely devastating, and it's also very hard to correct that diagnosis, actually. So keep that in mind. Here is just an example or a study that illustrates that. These are 476 patients referred to the Gainesville Autoimmune Disease Center, which is highly specialized. Now, the agreement between the presumed diagnosis for which the patients were referred and the final diagnosis was really very poor, about less than 50%. For SLE was about similar, and about 30% of all those patients referred had no autoimmune disease despite the positive ANA. And again, I think that these are numbers that change with the study but are very representative of the problem, okay? Now, the other thing is that you see that a fair number of patients that had positive ANA but no autoimmune disease actually received high doses of glucocorticoids. And again, that is not trivial. So in conclusion, many ANA-positive patients are misdiagnosed and may receive high dose of steroids, and it's highly important, according to the authors, but I concur with that, to emphasize the continued medical education of these issues as we are doing today. Certainly these patients, once they have suspicion of the disease, whether it's based on ANA or other reasons, they really benefit from referral to rheumatology to really move the process. Now, obviously, when it comes to the test, in the end, everything is about pre-test probability, post-test probability, and predictive value. So that's what you really want for a diagnostic test, okay? And here is just simply a summary in one recent study of how they behave, the immunofluorescence assay and the different solid phase assays in terms of those issues. And again, as you can see here in this summary, if you're, well, in general, you can see that the area under the curve is better for the solid phase assays in terms of post-test probability. But the pretest probability is extremely important either way. So if you start with a very low pretest probability, let's say a young woman with hair loss and arthralgia, very common manifestations in the population, even without lupus, then you see that your post-test probability is very, very low either way. If you go to a very high pretest probability, so the same woman now with photosensitivity, malar rash, and symmetrical polyarthritis, then your post-test probability after a positive ANA is very, very high. So it all depends on whom you order the test, okay? And that is very, very important. Now, how useful is a positive ANA in the general hospital? So here, patients referred to a tertiary rheumatology clinic for evaluation of ANA. What you can see here is that, once again, if you go to very low titers, but as high as 1 to 320, which is fairly positive, you see that the pretest probability for autoimmune rheumatic diseases is really still fairly low. I'm sorry, the positive predictive value is fairly low, and for any autoimmune rheumatic disease and for SLE is even lower. Certainly, as you go up in the titers, so the amount of antibody that you have, you improve, but still not in any great way. So you still stay about maybe 50% of positive predictive value of a positive ANA. So it's still not a great test from that point of view. Now, what were the common reasons for ANA testing in this study, which again, I think that it reflects well the problems that we face in general. Pain actually was the main reason, and you can see here different types of pain, widespread pain, mostly fibromyalgia, in about 25% of the patients with a ANA order. Hand pain, some other types of pain as well. Fatigue to some extent. So these are really the main reasons for ordering the test. And they ascribe these to the fact that the availability of the ANA testing has really spread, and obviously the use of the ANA testing for screening has also spread to multiple types of patients where perhaps, again, the pretest probability is quite low. And therefore, we are faced with a lot of false positives and misdiagnoses as time goes by. So within the chronic pain arena, which again is also what we see in terms of referrals with positive ANA, fibromyalgia is the third most common reason for referral to rheumatology. Up to 30% of fibromyalgia patients have ANA positive. So if you do the numbers, you get an idea of the false positives that we are going to get, which is most of them. About 15% of the population has widespread pain, but only about 0.1% of the population is going to have lupus at best. Therefore, you can see that the vast majority of these patients tested for ANA are not going to have lupus or any other autoimmune disease. Therefore, the chance for incorrect diagnosis of fibromyalgia as SLE is very, very significant. And in fact, an important study that was done at UAB a number of years ago showed that about 25% of the patients that are referred to a tertiary center for SLE actually had fibromyalgia with a positive ANA. Now, you could say, well, perhaps this is a good screening, though, in that those patients may have a higher risk to develop autoimmune disease in the future, right? But they don't. And there are good studies about that are quoted in here, showing that, in fact, if you follow these patients longitudinally, they are not going to develop autoimmune disease despite the positive ANA. Now, I told you that this is true, meaning the lack of specificity for diagnosis of autoimmune diseases, also in children, which for many years it was thought not to be the case, actually. That, sure, this happens in the older population, but if you go to a young child and they have ANA, for sure they are going to have disease. Well, that's not true either. And now that's being confirmed in many different ways. So this is one study where it shows very clearly, once again, that even if you have significant titers of ANA by immunofluorescence, your sensitivity and specificity are relatively low, and the positive predictive value is still very, very low. And remember that most people will call positive 1 to 40, 1 to 80. And at those levels, it's pretty much meaningless. And in fact, the conclusion of the study was that even at 1 to 160, which is significant in terms of the ANA, that result is found so frequently in children without rheumatic disease that a positive result has little or no diagnostic value. Okay, so once again, you have to go to the clinical context to interpret this result. And this was actually a confirmation of a study that very dear friend that unfortunately passed away a number of years ago, John Baum, actually did at the University of Rochester. And John was one of the grandfathers of pediatric rheumatology, although he was an adult rheumatologist, interestingly enough. But he trained in pediatric rheumatology in the UK, and then was really a seminal figure. And he did, I think that this is actually the first study in which they demonstrated that 1 or 2 years before this other one. Okay, so let's then go back and review a little bit of the history of antinuclear antibodies, the immunological basis and the implications for disease pathogenesis. And this will be brief. I'm not going to overdo this, but I think it's important to review history. So it was in about 1895 that Osler first recognized lupus as a systemic disease, not just the typical skin disease. And then it took about 50 years for the first in vitro functional ANA assay, essentially the ALE cell that I'll show you next, to be described by Hargreaves. And then a couple of years later, in 1950, Kunz actually described the method of tissue immunofluorescence and how to detect antigens in tissue by immune reactions. And then after that, it really took off. So people started to describe multiple other antigens and specific antigens that you could test for in lupus serum. And by about 1995, you had more than 100 antigens that had been reported in lupus serum that could be detected by immunofluorescence. And part of that improvement was also due to Eng-Tan description of the immunofluorescence assay and the different patterns at around 1978 using the immunofluorescence in the HEP2 cell line that, again, it has much more mitosis and more prominent antigens that improve the detection of the antibodies there, okay? And that's the situation that we find ourselves in now. This keeps growing. Now, perhaps in the last 5 to 10 years, the major development in the field, though, has been the description of this new pattern, which is the so-called nuclear dense fine speckle, or DFS70. Reported in about 2012, mostly in patients with interstitial cystitis, okay? And I'll tell you the punchline, the reason this is important is because you rarely see this in autoimmune rheumatic diseases. You do see it in healthy controls, and you do see it in other inflammatory and neoplastic diseases, but not in rheumatic diseases for the most part. So it's becoming a very important discriminating factor, but unfortunately there is no good test for that in the US. So labs will not report this immunofluorescence pattern, so we miss it. And there is no good antigen-specific assays, although they are in the market, but not in the US. So we'll see what happens with this, but it's something very important to keep in mind. Now, these are major contributors to the field of the ANA. So Albert Kunz, as I mentioned, that described first the tissue immunofluorescence approach. Henry Kankel at the Rockefeller described many of the ANAs and specific antigens and antibodies in SLE, together with Engtang in the beginning, which then contributed, as I mentioned, the ANA immunofluorescence patterns. And Doctors Burson and Yallo actually were responsible for defining or describing or developing the radioimmunoassays for hormone peptides. And Yallo actually received the Nobel Prize in 1977 for that discovery or method or development, whereas Burson unfortunately had died before the Nobel Prize was awarded, so he never received that. So I told you that we have, by this account in 2004, about 116 antigens now targeted by lupus serum. This is just to give you a summary of it. Many of them are nuclear or cytoplasmic and detectable by the HEP2 ANA. It's really fascinating from the point of view of the pathogenesis of lupus that actually this disease can not only make so many antibodies, but there are actually many of them, and the more important ones are made against factors that are implicated in DNA and RNA biology, and that obviously happen to be intracellular antigens. So a lot of the immunology of lupus really depends on understanding that, and we are still fairly primitive there. But I want you to compare that with what happens in diseases like myositis, for instance. So here you have a bunch of antigens that are targeted by the disease. They happen to be aminoacyl tRNA synthetases, and there is a bunch of them that are very similar antigens. And the point that I want to make is that in this disease, in contrast to lupus, you have either one or the other. It's exquisitely specific. If you have one of these antibodies, you never have the other, even though the antigens are very, very similar. So if somebody could understand that, we would probably understand the diseases. But it's just a huge contrast and a fascinating situation between the different diseases and how specific and mutually exclusive this is as compared to this. Okay. So let's go to the LE cell that I told you was the first ANA described. And in fact, it's essentially a functional counterpart to the ANA that is an in vitro artifact of incubation, first described by Hargreaves in the bone marrow. So this is the LE cell. Essentially what you see here is a neutrophil that has engulfed this swollen red nucleus without chromatin structure that is pushing the natural nucleus of the cell to the periphery. That's the LE cell. And the way this happens actually is incredibly informative because what it is really is this extracellular nucleus that for some reason is floating around in lupus that is recognized by anti-DNA or anti-nucleosome antibodies and now is phagocytosed by the neutrophil. Okay, and then it leads to the LE cell. That's essentially what it is, right? But it says that there are these anti-nuclear antibodies in the lupus serum that can do this. And that was, again, the first description of an ANA in the end, although he didn't understand it, obviously, at the time. But this is important because it's telling us a number of things. It's telling us, for one thing, that, again, those nuclear or that nuclear material some way or somehow is extruded in SLE and is available as an antigen. That SLE patients have these anti-DNA or nucleosome antibodies that can recognize the nucleus, that there is neutrophil activation that is prominent in SLE, and that this was a forerunner of DNA. Highly, highly specific for SLE, although not sensitive, and therefore very meaningful altogether. And so this sort of, if you follow this essentially summarizes what we know about lupus pathogenesis these days. So we know that there is a lot of cell death with apoptosis and release of nuclear material that somehow is not cleared in lupus as it happens in normal people. That leads to antigen presentation, formation of anti-nuclear antibodies, and those immune complexes are going to produce tissue damage, as well as activation of PDCs to release type 1 interferon, which is critical in lupus, and to activate neutrophils through the netosis or leading to netosis, release of more antigenic material, and essentially representing the basis, the immunological basis for the LE cell. So starting with this, you can now essentially put together all the aspects that lead to SLE. And this is also important in other ways. So one of the challenges that we face in lupus is to understand why the disease is so heterogeneous, why patients are different from other patients, why some patients develop nephritis and others don't, why some of them respond to some therapies and others don't. And that's the real challenge these days in SLE. So there's a lot of efforts that's illustrated here by this important paper in Cell in 2016, where whole blood genomics by transcriptional analysis was done of a large cohort of pediatric patients. And doing that, they were able to actually identify different groups of SLE that had different cellular responses. So you can see that there were two of them, in particular one that was characterized by the neutrophil activation that I described you in the context of the LE cell. And actually, those were the patients that progressed to having lupus nephritis. So this, once again, pathogenic cascade is very important, and it may explain actually some of the lupus groups and clinical manifestations. Now, because the LE was so specific for SLE and also representing the ANA, it was initially part of the classification criteria for the American College of Rheumatology that then disappeared more recently in the updated criteria, simply because it was labor intensive, it was not sensitive, and it had already been replaced by the ANAs anyway in better ways. So how do we test ANA in clinical practice? This, I think, is what you need to understand about the options that we have, right? So you have the traditional approach, the ANA by indirect immunofluorescence on HEP2 cells, again, able to detect more than 100 nuclear and cytoplasmic antigens in many different compartments. So very, very high sensitivity, because if you have antibodies against any of these antigens, you are going to detect it. Then you have the solid phase assays, where you have, depending on the company, depending on the test, you have from 8 to 20 purified antigens in a solid base phase assay, okay? So they are less sensitive, because if you have antibodies against any other antigens, it's going to be a negative, right, that you could detect by immunofluorescence. And of course, that also tells you that it depends on the disease, because if you are testing for Sjogren's, for instance, and the anti-Rho SSA antibody is present in all the solid phase assays, then for Sjogren's, probably it's going to be pretty good. It's going to be pretty sensitive, right? So it depends on the disease, and you need to know what disease you are testing for and what test really the lab is going to give you, okay? But altogether, it has higher specificity but low sensitivity. This is sort of the Bioplex 2200 that we will probably get at Emory, and that is really all over the literature. Okay, so it has 12 or 13 antigens. I'm not sure all of them are here, but I'll show it to you later. All right, so this is the way the immunofluorescence works. You incubate your HEP2 cells with different dilutions of the serum for titration. If the patient has IgG ANAs, it's going to bind to those antigens in the cells after washing and detecting with a secondary antibody. You look under the microscope and you define when it's positive, at which dilution it stops being positive, which is your highest titer, and then what type of immunofluorescence pattern are you going to see. And the more important ones are traditional ones are shown in here: homogeneous, speckle, peripheral, and nucleolar, okay? Now, in the lab or here, when you look at your results, what you need to do, although that is changing now, is to look at the result, which is going to give you the titer, how much antibody you have. But then you have to click on comments, because that's going to give you the immunofluorescence pattern, okay? And it can be just one, it can be mixed, like here, nucleolar and speckle, but it also will tell you whether there is cytoplasmic staining, which is meaningful for some diseases. And if it happens to be only cytoplasmic, which it happens, then the result for the ANA may be actually negative. And unless you click there, you will miss a positive anti-cytoplasmic antibody. Now, that may change now because more recently the lab is reporting this way, and now you have different areas where you can actually check for all those results. You still have to check on comments, though, to find what's going on. All right. So solid phase assays as opposed to immunofluorescence, which ones are available? Well, ELISA, which you all know about, is highly used for some ANA tests. And then these are the multiplex assays where in different either solid phase or fluid phase, because the bioplex, for instance, functions by flow cytometry, but they all have beads that are coated with the antigen. And there is some detection method, whether it's by fluorescence or chemoluminescence or so forth. And so again, here the key, this is the bioplex by flow cytometry. These are the 13 antigens. What is critical to understand is that you have a limited number of antigens that the test is going to detect. And if the patient doesn't have those antigens, it'll give you a false positive. Okay. Now, this is a big dilemma. This, believe it or not, I got it through the ACR Division Directors Group last week. And it was yet another academic division panicking because they thought that the hospital was going to take away their immunofluorescent ANA, and they are asking for help. How do we argue that we need our immunofluorescence ANA? And yes? Do you want us to walk out of the room from this part? No, I'm stopping there. I'm not going to take sides. But it's a real issue. So we rheumatologists are really attached to our immunofluorescence ANA, and we want to keep it. So they are actually behind the curve because this has happened already everywhere. So again, I told you already what the advantages and disadvantages are in terms of sensitivity, specificity, and also obviously there are practical issues. The immunofluorescence is labor intensive, it's highly specialized, long turnaround time, lack of inter-observer consistency. On the other hand, the solid phase assays being more specific, but there is much less validation of them, much less experience in large cohorts over time, poor validation in many cases, and low agreement. On the other hand, they are automated, they have high throughput, and they have short turnaround time. So there are advantages and disadvantages. All right. So I think that we have talked enough about that. This is the type of result that you get with immunofluorescence, the different patterns that I showed you before that are typical, that give us, I think that this is really more for rheumatology consumption than anything else. Once the patients are referred, based on the different pattern, we make assumptions about the type of antigen that is going to be there and what type of diseases are more likely the patient to have. But the reality is that then once you see this positive test that is convincing, you are going to move on to the next step, which is to order specific antibodies and really be certain about all these assumptions that we made based on the pattern, okay? Again, just to remind you, the new one, the nuclear dense fine speckle, DFS70, that is seen mostly in healthy controls and many other conditions, but no in autoimmune rheumatic diseases for the most part. This is just to show you in a large number of tests that about 50% of the ANAs by immunofluorescence happen to be negative. The majority of them, 90%, are nuclear, and of those, almost 50% are the DFS70. That almost excludes rheumatic disease. So this is very important to keep in mind, but we don't get these results. And this is just to show you that with the exception of Sjogren's, where there is some positivity, really only about 2.8% of autoimmune rheumatic diseases will have this antibody, okay? So it's very, very much negative in our diseases, whereas it's positive in the healthy population and in a number of conditions that are highlighted here, and it keeps growing. So it really leads you away from autoimmune diseases. All right. So on the basis of all of that, the ACR recommendations, the American College of Rheumatology took a stand here and essentially decided that the immunofluorescence ANA is the gold standard for the reasons that I mentioned, that it has very, very high sensitivity for SLE, although poor specificity, and that healthcare providers should avoid ordering the subserologies to break down an ANA into a specific autoantibodies if there is no clinical context that indicates that, again, because of the low specificity of the ANA. All right. Now, these are the diseases, though, that if you are thinking about them, then the ANA is very important. That's where the ANA helps you in different ways. SLE, mostly for the diagnosis, although it's not mandatory. You could have, in a very low number of cases, SLE without ANA. Systemic sclerosis, important for the diagnosis, helps there. Same for polymyositis and dermatomyositis, although you see that the sensitivity goes down, so you shouldn't really exclude those diseases for a positive ANA. Now, in juvenile idiopathic arthritis, what it does is to identify a group at a higher risk for uveitis, and therefore you follow them more closely with ophthalmology because it can be a devastating complication in those children. Autoimmune hepatitis type 1 is part of the diagnosis. Raynaud's phenomenon, if you have a positive ANA in a younger person, new onset Raynaud's, and mostly these capillary changes in the nail fall, then the risk for systemic disease is fairly high, and so you follow those patients closely. So those are the situations in which it helps. For anything else, you don't really need an ANA anyway. Okay? And this is just very briefly to be sort of Solomonic here and say that despite our attachment to the fluorescent ANA, there may be a role for actually combining the tests for screening. And this is just a study that shows that if you actually do double positives for immunofluorescence and some of the solid phase assays, actually the likelihood ratio is going to go high, much higher, relative to just the immunofluorescence, okay? So there may be a role for actually combining the two for screening. And as the solid phase assays keep getting better, validated, consistent, and include more and more antigens, then our view might change, okay? But this is the way it is right now, really. Okay, now, let's review that again. ANA test by immunofluorescence is not specific. You see here that many different diseases may have it, but also many other autoimmune diseases, and as I told you, healthy controls as well in large numbers. The other thing is that many antibodies, specific, so-called specific antibodies that you order one by one or in multiplex panels, actually are not specific for any disease. U1-RMP can be seen in many other diseases other than MCTD, RHO and LA or SSA-SSB, usually called Sjogren's syndrome antigens, actually are very low specificity or have very low specificity for that disease and can be seen in many other diseases as well as healthy controls. And this is a problem even for the New York Times, okay? So, a couple of weeks ago, I don't know if you read this feature of the Sunday magazine, it's quite interesting. So in this case, this was a 54-year-old man that had just had the flu, and then his heart could barely pump, okay? So finally, a rheumatologist found an answer. The patient tested positive for something called Sjogren's syndrome. Now, the tested positive, I think, is already a giveaway because you don't test positive for Sjogren's syndrome, right? In any case, they were thrilled to have a diagnosis, although they thought that it was unusual to have these type of problems with extraordinary fluid retention. And therefore, and we rheumatologists are very good for that, we theorized a second disease called undifferentiated connective tissue disorder, which we use when we don't know what's going on, might be involved, okay? Now, the patient was immediately started on 2 immunosuppressive medication, not 1, but 2, because he had tested positive. Okay. Now, when a remedy fails, at some point he was on 4 of these medications, but he was not doing well, okay? I didn't believe it was his autoimmune diseases, even though he had Sjogren's and possibly UCTD. So they had already assumed that that was the case, and I'm assuming that was based on an antibody test. In any case, they went back to the heart and they realized that the patient had actually restrictive pericarditis, and they solved the problem, okay? So I don't think, although obviously I don't know all the information, that this patient ever had Sjogren's, needed any immunosuppressive medication, and certainly that did not account for this really refractory case. But that's just an example of what happens. So let me just take 5 minutes to close this down and go back to sort of contradict myself in a way. So we are saying that we shouldn't be using ANA for screening of the population. But we are in the era of predictive medicine and personalized medicine. So are things changing to the point that we should actually screen the general population or even populations at risk to decide who is going to develop lupus or similar diseases? Now, this is how people look at precision health, how these biomarkers could help. And in our case, if we can actually define risk for the development of our diseases, then we can treat before the disease actually develops. And the closer than we are, and fairly close actually, is with rheumatoid arthritis, where there is already good evidence that if you have CCP antibodies, at least 2 of them, in 2 to 5 years, about 40 or 50% of that population will develop rheumatoid. And on that basis, people are treating in a preventive fashion, okay? These are some of the studies that are going on. And this is some of the evidence. I'll skip over that. Now, we know that for lupus is also true. It was described a number of years ago that about 10 years before the onset of lupus, you actually already have ANAs, and then other antibodies add up until they get multiple of them just before clinical onset. So lupus is sort of the similar thing, and I showed you this before as well. So the question is, do we know which one of those are going to develop disease? In general, the predictive value is not good. So that's the point that we have. We are going to have to add other immunological variables and genetics to define which of those healthy ANA-positive subjects are at risk to develop lupus. So right now, for lupus, we're still far away, but that would be, in the context of research, a reason to screen populations at risk. And this is a game changer paper if somebody reproduces this, and I have a number of problems with it, but just to share with you. So this is a study actually done in Spain in which they took 411 patients that had been positive by bioplex screen, did not have clear autoimmune disease, and then they followed them over 3 years. Now, if you had followed the literature, you would have predicted that those patients were not going to develop any autoimmune disease, right? And yet, they found that although that 76% of subjects that were that were positive by bioplex but negative by immunofluorescence at entry, then over those 2 or 3 years actually develop a positive immunofluorescence, and a very large fraction of them develop autoimmune disease. So there are things here that don't make sense. This may have been a highly skewed referral population. And anyway, technically, this doesn't make sense because the bioplex antigens that were positive at baseline should have detected a positive ANA by immunofluorescence. So somebody is going to have to reproduce this study that just came out. But if this is true, we are going to have to somehow think again how we do things. All right. So this is the recommendation of how we should do things at this point. High pretest probability, do ANA screening and confirmation. We could use either one. We prefer the immunofluorescence assay, and if positive, then go to the individual antibodies. But we could do both, and we could do double reflex from one to the other. If they are positive, certainly by immunofluorescence, we want to know the pattern and the titer. If they are negative, then we know that there is no autoimmune rheumatic diseases, although there could be ANA negative lupus. There could be other diseases that are negative for ANA, including scleroderma and myositis, and then you order those panels. If it's positive, again, remember, a lot of healthy subjects, no autoimmune rheumatic disorders, including infections, malignancy, and drug-induced, and therefore a positive test is not diagnostic. This is what you can order here at Emory, either the screening tests. This right now is the Symphony rather than the Bioplex, but it may become the Bioplex. And then these are the individual tests and the different panels that can be sent either for a scleroderma, myositis, or interstitial pneumonia with autoimmune features. They can be ordered to get all those antibodies at once. And just in closing, recommendations. So choose wisely. And this summarizes a lot of what we have said. Don't order ANAs as screening tests if the patients don't have specific signs or symptoms of SLE or other connective tissue disease. Don't order autoantibodies panels unless there is a positive ANA and evidence of rheumatic disease. Don't repeat a confirmed ANA positive if the patient have JIA or lupus. There is no value in repeating the test. It's only money. Don't test subserologies if the ANA is not positive and you don't have a clinical suspicion of a specific disease. Testing ANA and ENA should be reserved for patients suspected to have a diagnosis of connective tissue disease such as lupus. Testing ANA and ENA should be avoided in the investigation of widespread pain or fatigue alone, and repeat testing is not normally indicated unless the clinical picture changes significantly. So that is the complexity of the ANA field, but hopefully I made it a little bit simpler than that and gave you some useful information. So I will stop there and we'll be happy to take questions. Thank you.
Thank you, Naki, for that great review. I have a question about the nuclear dense fine speckled, and it sounds like that's not routinely available, but it sounds like that's really the 8% or so of those individuals who are otherwise healthy would have that particular pattern. Is that not useful?
It is. So you can do it in three different ways. One is by the immunofluorescence, and it's just most labs are not aware of it, and it's not reported, although it's been recommended by the International Society recommendations. So it has to be by immunofluorescence. There is a company that has an antigen-specific DSF70. For some reason, is not available in the U.S., so we don't get it. And what people are recommending now is an absorption test, where actually the serum is absorbed against the antigen, and then you do the immunofluorescent test so that you eliminate this sort of false positive. So it has to change. It's an important one that, in practical terms, we are not getting. We or any other place in the U.S., I don't think.
Yeah, Iñaki, that was a great talk. Thank you. If I understand you correctly, and keep in mind there's a very good chance I did not, it sounds like autoantibodies are necessary in many cases to develop a rheumatologic condition, but not sufficient by themselves. That is, it seems like the vast majority of these antibodies are of no clinical significance or benign. If you look at the general population, if you're saying that 15 or 25% or whatever people have this. So what is the second step? It sounds like in these diseases, an autoantibody may be necessary for the pathogenesis, but by itself has a very low prediction to go on to the disease. So what is the second immune step with these autoantibodies that creates the lupus, Sjogren's, whatever it is that people have?
Well, it depends on the antibody, right? So I think that there are some antibodies, anti-DNA might be the perfect example, that are much more likely to be pathogenic, right? I mean, it's been isolated from the kidneys in patients with lupus nephritis, so on and so forth. But in most cases, you're right. So what the second step is unclear. Most people argue that it's a couple of things. One is that there has to be maybe some pre-existing inflammation or somehow tissue susceptibility for those antibodies to get there and induce damage, right? And the other thing is what is called epitope spreading, right? So you have the antibodies, but in the beginning are more of housekeeping antibodies. They may recognize the same tissue, the same antigen, but they don't have pathogenic properties. As that keeps increasing and the antibodies mature, maybe by selective rounds of affinity maturation and selection, then they become more pathogenic. But what the threshold is and how you get there, we just don't know.
Representing the lab here, David Alter, I'd like to speak about the DFSP, and Dr. Sanz, I apologize, I haven't read the reference that you sent me yet. The rate-limiting factor for labs that do the IIFA test is whether or not our proficiency organizations and competencies and training groups provide patterns for it. So it's, in my experience, it's not the first time that there is a finding in either UAs or ANAs or others where it's been reported in the literature or even the textbook literature, but has not reached the level of the laboratory reporting parameters. So in some respects, we're sort of hogtied by that. And if it's not been handed off to us by either the company or the CAPR College of American Pathologists or the ASCP as a reportable entity, we're probably seeing it but not reporting it.
Yeah, so
and
the paper...
And I failed to do my homework here. I should reach out to ARUP, our lab, where we send our IFAs, and maybe even Mayo Clinic, where they have a large immunology section, to see what their response is to the DFSP findings.
Yeah, again, this came to the attention of the International Nomenclature Committee a few years ago. I actually happened to edit this paper where actually the recommendation in the end was that it had to be reported. And I can tell you that through the reviewers and the entire review process, that was a contentious issue. But in the end, the unanimous recommendation was that this was important to recognize and very important to report. As you know, it hasn't made it yet, I don't think. But
sometimes there's a big leap between this type of recommendation and and as you know, what gets incorporated into general practice.
Yeah.
Thank you, Iñaki. I just wondered if there was a change in predictive value if you take into account isotype on top of traditional targeting, right? If you would see in children maybe less class switching, less mutational progression, things like that.
Possibly. I mean, it makes a lot of sense that it might, but the tests are essentially done for IgG, so I don't think we know.
Great. Thank you very much, Inaki. That was outstanding.